The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Okay, thank you for the invitation and opportunity to present today. So I'm lucky last in this debate on who should be the primary responder. I was given the topic that the paediatric nurse practitioner should be the primary responder, and that's quite fitting for me because I am a paediatric nurse practitioner who is a primary responder. More specifically, I'm a paediatric critical care nurse practitioner. For those of you who don't know what a nurse practitioner is, the International Council of Nurses defines a nurse practitioner as a registered nurse who has acquired the expert knowledge base, complex decision-making skills and clinical competencies for expanded practice, the characteristics of which are shaped by the context and or country in which he is credentialed to practice. The nurse practitioner role has existed internationally for several decades now. First established in North America, followed by a subsequent rapid program throughout the United Kingdom, originating to fill service provision gaps and increase equity of access to healthcare. Here in Australia, evolving out of necessity for remote communities, the nurse practitioner role now exists in primary and acute care in both rural and metropolitan Australia, covering many specialties including paediatrics, mental health, palliative care, aged care, family health, emergency and critical care. For Australian nurses, the last decade has seen extensive professional activity along the nurse practitioner pathway with regards to education, professional activities and government legislation. Around the globe, many different roles exist under this umbrella of nurse practitioner or advanced practice nurse. However, here in Australia there is one official protected title under which NPs are authorised to practice by the Australian Health Practitioner Regulation Agency. A rigorous endorsement process exists that has evolved concurrently with formalised education at master's level. Over the years, the nurse practitioner role definition has created much national and international debate with regards to validity, acceptance, role conflict and role confusion. Measurement of the impact and values of nurse practitioners has proven difficult, with the mainstay of evidence comprising of comparison to doctors, cost analyses and satisfaction surveys. Nevertheless, in many healthcare systems, nurse practitioners have been credited with having a positive effect on patient outcomes and the role viewed as important in the provision of appropriate, efficient, cost-effective and highly regarded care. Recognition of the widening gap in available resources and experience between the intensive care and the wards, perhaps partly due to the increasing complexity and volume of intensive care, has led to the innovation of extended nursing roles in critical care areas. Internationally, nurse practitioner roles in PICUs were usually introduced to fill a void resulting from medical staff shortage and were based on medical models with varying responsibilities, skills and supervision. Our paediatric critical care nurse practitioner role is the first of its kind in Australia and is a unique role within this setting as coordinators of the Paediatric Intensive Care Outreach Service and expert responders to the deteriorating child. At the hospital where I work, the Children's Hospital at Westmead here in Sydney, the PICU-NP role commenced in 2003 with 2 full-time positions, and over the ensuing initial years established a nurse practitioner coordinated ward liaison service, which we now term the Paediatric Intensive Care Outreach Service, or PICOS. The nurse practitioner team has grown and now consists of 5 endorsed nurse practitioners sharing 4 full-time equivalent positions. There's not yet enough of us to provide a 24-hour nurse practitioner service, and out of the NP hours, the PICOS is covered by a PICU registrar and a senior PICU nurse. Now, following recommendations from an inquiry into the preventable death of a paediatric patient in New South Wales Hospital, a statewide program called Between the Flags, which I'm sure many of you here know, incorporating an early warning system and guidelines for appropriate response to deteriorating patients was developed. In February 2011, this program was introduced across our hospital as the pilot centre for paediatric patients in New South Wales. The PICU nurse practitioners were heavily involved in this process, from the development of the standardised track and trigger paediatric observation charts through to the local implementation of the rapid response team. This system is now well established, with the PICU nurse practitioners coordinating the outreach service and this service being an integral component of the rapid response and arrest teams. The aims of our original ward liaison service and the current PICOS were and are to extend critical care services beyond the walls of the PICU. early recognition and escalation for deterioration, to prevent or facilitate transfer to the PICU, preemptive transfer of patients requiring high dependency rather than intensive care, decrease unplanned admissions to the ICU. Routine provision of follow-up assessments is a feature of our outreach service that distinguishes it from other organisational systems designed to respond to deteriorating patients, such as the Met, which sees patients as a once-off for deterioration. And also to develop the skills of the ward healthcare team in the assessment and care of acutely ill children. So what do nurse practitioners have to offer in this setting? They have a defined skill set focusing on the deteriorating child and work within an authorised scope of practice, which incorporates advanced assessment, diagnostic ordering and reasoning, decision-making, prescribing, vascular access, airway management, resuscitation, stabilisation, and team leading acute situations. Knowledge of equipment and monitoring, and the ability to commence intensive care management outside of the PICU and care for patients on the ward whilst awaiting an ICU bed. Provision of care and management plans appropriately contextualised to available local resources and expertise, as well as patient need and the trajectory of illness. The PICU nurse practitioner does not have a direct patient load within the PICU. Therefore, there is less impact on ICU resources when a prolonged amount of time is required to be spent on the wards with deteriorating patients and following up identified patients either after deterioration or after discharge from the ICU. This role provides a consistent, high-quality workforce since nurse practitioners do not rotate regularly like doctors. Once you invest in them, they tend to hang around and they're in for the long haul. They offer a high level of awareness of organisational policy and procedures, as well as the day-to-day running of the hospital. They understand staff ratios and patient acuity in relation to the strengths and weaknesses of individual ward area specialties. Investment in engagement with children and their families, advocating for optimising communication and teamwork, ultimately participating in moving towards a safer culture throughout the hospital. Although the main responsibility of the nurse practitioners is leadership of the outreach service, the MPs are also involved in clinical support to the ICU, education and training, simulation, safety and quality projects, incident management, policy and procedure development, and research at various levels. And in addition to holding relevant memberships with various external professional organisations, the PICU MPs are all certified advanced paediatric life support instructors, and collectively and individually have utilised the role's expertise to contribute to chapter authorships in statewide training manual for detection, management and escalation of potentially deteriorating hospitalised children. If anyone's interested in more details of our role and its evolution, I can direct you to our publication in the Pediatric Intensive Care Nursing Journal. So now you know the context of the work of the PICU nurse practitioners, I can now share some of the PICU outreach service data and outcomes at the Children's Hospital at Westmead. So this is the number of clinical reviews carried out by the outreach service since its commencement. These total numbers are inclusive of arrest calls, rapid response calls, outreach calls to the wards and the emergency department, and patient follow-ups after initial review. The sharp increase in calls from 2010 to 2011 corresponds with the introduction of the Between the Flags system. We classify our outcomes into 4 categories: remaining on the ward, PICU admission for high dependency care, PICU admission for intensive care, or death. The data in this slide shows the breakdown of these outcomes for all PICOS activity since its establishment. Despite the increasing activity of the service, the majority of children remain on the ward, and the majority of those admitted to the ICU are for high dependency care rather than intensive care. We've heard a little bit about dose this morning. It's been agreed that the standard method for reporting rapid response team utilisation rate should be the number of calls per 1,000 patient admissions, and this is referred to as dose. This dose measurement assesses the rate of crisis detection and activation. The literature suggests that increasing dose leads to improvements in outcomes of hospitalised ward patients, and some studies have shown a reduction in the rate of cardiac arrests and a greater effect with a greater dose of care from the rapid response team, with the suggested effective or mature system doses between 26 and 56 calls per 1,000 admissions. So what is our dose? As you can see, our dose has steadily increased, and in recent years is between 40 to 50 calls per 1,000 admissions, corresponding with the effective dose described in the literature of mature systems and comparable to that of the adult world. Note that the PICU admission rate has remained fairly static. This is a very similar slide to the one I showed you before, but these outcomes exclude follow-ups and exclude the emergency department and other critical care areas. As you can see, most stay on the ward, more come as high dependency rather than intensive care. Deaths on our wards, thankfully, are very rare, with none last year. Our current work involves analysing our mortality trends. This graph considers each group's mortality as a percentage of admitted patients. Hospital mortality in the green is fairly static, and the overall PICU patients and those PICU patients admitted via the outreach service from the wards, a reducing trend is seen. And when looking at the relationship between dose and mortality in ward patients admitted to the PICU via the outreach service, we see a downwards linear line. We're presently working on the analysis of this and publication of this data. So returning to the concept of the deteriorating patient and the rapid response call, these are the necessary elements. The patient, fairly self-explanatory. The parent or carer or relative who has intimate knowledge of the patient. In paediatrics, this element is particularly important for us for discerning what is usual or normal for that child. And for us, carer concern is amongst the calling criteria triggers. There's the treating team, which you heard about from Robert. They hopefully know the clinical background of the patient and the reason for their admission along with recent events. And finally, it's the fresh pair of eyes. It's this fresh pair of eyes, this ICU response that we're debating today. Who should be that fresh set of eyes? So what characteristics are essential of the primary responder? I put to you that you need intensive care expertise and a defined skill set in dealing with acutely unwell, deteriorating patients. Proven knowledge and training, experience and credibility, a team dedicated to their core business, in-depth organisational knowledge and awareness, and finally, but perhaps most importantly, a commitment to a culture of safety and a passion for improving the quality of care and service delivered. All of these characteristics I describe are inherent to the role of the paediatric critical care nurse practitioner. In conclusion, after nearly 15 years of a dedicated nurse practitioner coordinated paediatric intensive care outreach service, we maintain the objectives of improving patient outcomes, improving the quality of patient care and patient experience, reduction of adverse clinical events, sharing knowledge and skills, and improving the delivery of comprehensive care to sick children across organisational and professional boundaries. The paediatric nurse practitioner should be the primary responder. Thank you.